All right, good afternoon, everyone. My name is Kat Patterson, and I am a senior analyst on the Maternal and Child Health team at the Association of State and Territorial Health Officials, or ASTHO. I'm excited to welcome everyone to our first virtual learning session for the Promoting Innovation in State and Territorial MCH Policymaking, or PRISM Learning Community. This learning community is co-organized by ASTHO and the Association of Maternal and Child Health Programs, or AMCHP. If you haven't already, please take a moment to let us know where you're joining us from and type your state into the chat box. Today's session will discuss universal screening and testing for substance use disorder, a topic relevant to the policy goals that many of the teams represented here today are working on as part of this learning community. The objectives for today's learning session are to describe the differences between universal screening and testing, delineate the process by which Indiana developed and advanced legislation on universal screening, and articulate possible ethical and legal concerns around universal screening and implementation. Before we turn it over to our speakers, we would like to state that the content, findings, and conclusions shared in this presentation are those of the speakers and do not necessarily reflect the official position of or endorsement by either ASTHO or AMCHP. Please do not hesitate to reach out to any member of the ASTHO or AMCHP teams if you have any questions about this disclaimer. We'll now introduce our first speaker, Dr. Scott Wexelblatt. Dr. Wexelblatt is the Regional Director of Newborn Services at Cincinnati Children's Perinatal Institute. You can find all of our speakers' bios in the document attached to the calendar hold for this event. Please type your questions for him in the chat box, and we will answer questions at the end of all three presentations. Dr. Wexelblatt, the floor is yours.
Thank you very much. Can you hear me okay?
Loud and clear.
Great. All right, so next slide. So I'm going to be talking about universal maternal drug testing and what we've been doing in Southwest Ohio. And the reason and give you a background on why we did that. So the next slide is going to just give an overview on what we are, when I talk about neonatal abstinence syndrome, it's also commonly known as neonatal opioid withdrawal syndrome, but I'm just going to refer to it as NAS for the rest of the talk. So signs and symptoms associated with opioid withdrawal occur in most babies, anywhere from 55 to 95%. However, only 20 to 50% will actually need pharmacologic treatment to get through this withdrawal. One of the problems with NAS, though, is the onset of symptoms is delayed. So the average timing for a baby to need pharmacologic treatment is 44 hours. And so that becomes an issue in trying to identify a baby prior to discharge, as a lot of women are discharged around the 36-hour mark for vaginal delivery and 72 hours for a cesarean section. So next slide is going to show what we've been seeing in Ohio. And the next slide is going to give you an overview of the diagnosis at the time of discharge per county. So this is a map of Ohio broken down into our 80 so counties. And you can see, and this is a 5-year weighted average. And so at the end of 2008, you can see we were seeing around 6 per 1,000 was the rate of the diagnosis of NAS at the time of discharge. And then we're going to go through the next couple of slides. So it's going to show in 2009, it starts to spread more. In 2010, on the next slide, you're going to see our first county started to get above 1%. So it was 14 per 1,000, or 1.4% of all of the births in this county had a discharge diagnosis of neonatal abstinence syndrome. And unfortunately, over the next couple of slides, we're going to see this color continue to spread. So the next in 2011, it becomes more. Next slide on 2012 is going to show even more of the spread in the southeast part of the state and coming now to the south central. And then 2013, it becomes more apparent. And then the next slide is going to really give us a good comparison of what we were seeing in 2008 to 2015, where the majority of our counties are having the diagnosis of NAS above 10 per 1,000, or more than 1% of all of our diagnoses are having the discharge diagnosis of neonatal abstinence syndrome. In our city, on the next slide, we're going to see this defines the Cincinnati region, makes up of these hospitals. And the next slide is going to show you that we've been seeing for the past 5 years, more than 3 to 4% of our babies are being exposed to opioids in utero. And this is a 677% increase from the year 2009. So 38 per 1,000 last year, almost 4% of all of our births were exposed to an opioid in utero. And the next slide shows what we defined as neonatal abstinence syndrome are those babies that need pharmacologic treatment to get through their withdrawal. And so it's been pretty consistent for the past 5 years that more than 1% of all of our births in our city are requiring pharmacologic treatment, either methadone, buprenorphine, or morphine to get through their withdrawal. And then this next slide is going to give you an overview of any substance that includes opioids or any other illicit substance, prescribed opioid. And you can see we're almost around the 9% mark for the last 3 years of having moms having either illicit drug use or prescribed opioid for the past 3 years. So the next slide is trying to say, how can we identify these infants prior to discharge? And so what we need to first differentiate is a screen versus a test. So a screen is either a questionnaire or a checklist that you would do to say, do I have a positive screen? Whereas a test gives you a result, plus or minus, or a number. So the next slide is going to show you what the American College of Obstetrics, ACOG, recommends. They recommend universal screening. And they recommend this to be at the first visit. And then if you do recommend a test, that you would go ahead and get consent prior to this test. So in their statement on the next slide, they're going to show us 2 easy screens that are easily done. The first one are the 4 Ps. You ask about 4 questions about your parents, partner in the past or currently using any. And you can see under their scoring, a 1 yes to any of that would be a positive screen. The CRAFTS questionnaire is used often too. That's 6 questions. 2 or more positive indicates a positive screen to further assessment. The next slide is going to show you what we are moving towards. And then, great. So this is the NIDA Quick Screen, developed by NIDA. And this is the screen that Maternal Fetal Medicine Group Society is going to be coming out with a recommendation sometime this summer in their next paper. The difference between this and the 4 Ps in the CRAFT, it breaks it down to alcohol, tobacco, and illicit substances and prescription substances. And so if you say yes to one of these, next please, you'll see then it's going to ask you questions about use in your lifetime. And the next will come up, what about currently in the past 3 months? And so then this is a screen, and you can see their scoring based on what you answer. And then the next slide is going to show us what you do. So a positive screen is greater than 4, and then depending on how much of between above 27 is a high risk, that's when you would actually make an arrangement. But that's how you can do a different screen. On the next slide, we're going to talk about testing. So there's 2 different types of main tests that we can use. One is an immunoassay. It's super quick, takes 1 to 2 minutes. It only can give you a positive or a negative result. You can buy these at CVS and Walgreens. It's easy to perform. The problem is that can be some false positives and false negatives based on diets or medications. But one of the benefits is that it's immediate result. You have a cutoff value that's built into it. So if your cutoff value is 200 and your value is only at 199, that's going to come off as a negative, even though, because you're not above your positive cutoff value. So there's definitely some pluses and minuses with this. So the gold standard is on the next clip. It's called mass spec. If you can hit next. So mass spec gives us an absolute number as a result. So you're going to get 455, 3,022. The problem with this is it takes a full day to get a result. You need a fancy machine that you see in the bottom left and a PhD to determine these results. And so it's much more expensive. It's a longer turnaround. There's not that many labs that are able to perform mass spec. So that's the holding block on using that universally. So next slide is going to show us, we looked at a study reporting screening versus a testing. And so we actually asked moms at one hospital based on self-report. It was 8.6% of the women said they use cigarettes. But you can see on the next clip that actually when we test their urine, we actually detected 16.5% of the women actually had high levels of nicotine. So we know just screening for nicotine use, which is legal, we're definitely going to miss twofold of the women that are actually positive in their urines are not going to be telling us the truth when we talk about nicotine, let alone any illicit substance. The next slide is going to show us, we did a pilot study at one hospital, the Mercy Anderson Hospital. They deliver around 2,000 women a year, 96% are Caucasian, 52% are married. And we had a risk-based test, a screen on the bottom that you can see. And the next slide is going to show that we were able to go ahead and test 3,000 women. And we then went ahead on the next slide. We looked and said, of all the positive tests, which ended up being 5.4% of these women, next slide, please. What percent were positive for opioids? Next. And then we wanted to say, what happens if we actually, did these women have a positive screen or a negative screen? So if they had a negative screen, next, we would have never identified these 20% of our positive opioids because we wouldn't have tested them. They had a negative screen on admission. We wouldn't have known that the mom and baby were positive for opioids. So then what we wanted to do is follow this cohort and say, did it make a difference that we were able to identify these infants prior to discharge? Next. And you're going to see that the number of negative risk-based screen infants that needed additional care for signs and symptoms of NAS was actually a third of those babies that we picked up. So we realized that just having a screen for opioid or illicit use, we were going to miss a good amount of babies that actually had signs and symptoms and needed treatment for withdrawal. Next. So what we decided to do is in September of 2013, we went regionally. We knew we couldn't have just one hospital doing universal testing and the rest just doing our traditional screen. So we went to something called the Greater Cincinnati Health Council, which is made up of all of our regional hospitals. And we realized we had to do it at all hospitals. We couldn't have hospitals X and Y doing it and not A and B doing it because word would get out. We recommended DUA 13, that's an immunoassay for a quick screen. The 13 tests for 13 drugs because that's the only one that can detect buprenorphine, which is being commonly used in our region. We also recommend sending out for confirmation, mass spec, if mom denies her positive immunoassay or denies the use of any of their substances that show up. So the next slide will show that actually currently we have 18 hospitals in our region, and you can see these are the hospital systems. Some of them have multiple delivery hospitals, but we have 18 hospitals doing universal testing, which is around a little over 25,000 deliveries. Next. We do ask for consent. Next. And you can see that we just put it in plain language that I understand for the safety of my infant, blood and urine will be obtained. We're going to be testing all moms in our region for syphilis, presence of drugs in controlled substances, and we also talk about anemia and other blood disorders. So we do obtain a special consent for all moms for maternity on top of the regular hospital admission. Next. And so some of the benefits that we found about implementing universal testing is that we can start non-pharmacologic bundle earlier. We actually know all of our opioid exposed babies by the time they leave labor and delivery and show up to the postpartum unit. Another thing that we have found is by doing this early identification, our hospitals in our region, our 14 hospitals that our group covers, we're treating anywhere from 28 to 30, around 30% for the last 4 years pretty consistently. And our OPQC, our Ohio Perinatal Quality Collaborative, we've just been working on for the last 4 years, showed that our statewide average was 42%. So early identification allows us to set up the parents to have the best possible outcome. And a couple of our hospitals, over 4,000 deliveries, of both, 2 hospitals above 4,000 deliveries are only treating 22% of our cases. Next. So some certain things that our OBs are currently doing universal testing for that every mom who's pregnant gets tested for. It's hepatitis B, syphilis, and HIV. These are the rates in 2016 for women in Ohio. You can see this is a rate per 100,000. And if I add opioid onto this on the next slide, you're going to see that the rate is 3,300. As we stated earlier, it's around 3% of all of our women are positive for opioids. But to get that in context of hepatitis B, syphilis, and HIV, it's not even comparable. So what we're dealing with now has definitely changed from what we've been dealing with when we started doing our testing rates for pregnant women. Next slide is going to show we always got a lot of concern from people that we're just going to overwhelm our justice child custody cases. So looking at our Hamilton County, our main region that we do universal testing next, you're going to see that in 2014, if you click next, you can see that the first we'll go back one more. I apologize. You can see the first year that we did universal testing compared to 2013. We actually didn't have an increase in new cases coming into custody. We do see an increase in 15 and 16, but if you go back to that initial slide, we actually were seeing an increase in usage. So just by doing universal testing, which we started in the last quarter of 2013, we didn't lead to an overwhelming increase in cases going into custody. And so now I'll turn it over to our next speaker and stay on to answer questions at the end.
Thank you so much, Dr. Wexelblad. As a reminder to our attendees, please chat your questions into the chat box, and we'll be answering them at the end after we've heard all three presentations. So without further ado, let me introduce Dr. Christina Box as our second speaker. Dr. Box is the State Health Commissioner of Indiana and a champion for women and babies in her state. Welcome, Dr. Box.
Thank you so much, Kat. I am also an obstetrician gynecologist for the past 30 years, so it's a pleasure to have the opportunity to speak today. I want to say that this next slide started because of the intersection of significant issues here in Indiana, that we have the 7th highest infant mortality rate in the nation and at 7.3 infant deaths per 1,000 live births, and the 3rd highest maternal mortality rate in the nation. We're also in the top tier for drug overdose deaths in the nation. And we know from looking at our infant and maternal mortality review committees that we are losing moms and babies related to this drug epidemic. Specifically, we know that we have had key risk factors like increase in low birth weight and preterm labor and birth, which when you look at national statistics, is usually low birth weight 31% in substance use disorder versus 5 to 8%, preterm labor at 25% versus 9.6%. We've also had greater than 5,000 children added in the past several years to our foster care system related to opioid use disorder alone, with a 500% increase since the year 2000. So we looked at short-term and long-term complications. Next slide, please. This just shows you basically that 44% of our female opioid deaths are in ages 20 to 40, which are prime childbearing years, as everyone knows, and that OB, we know, is an opportune time to be able to identify women that have substance use disorder and get them referred to treatment. We know that women are much more likely to seek treatment and accept treatment when they're pregnant or have a newborn at home. Next slide. So we actually tried to take a public health approach to this in, first of all, obviously preventing unintended pregnancy or helping women with known substance use disorder to prevent pregnancies until they were at a better stage in their life to be able to conceive and carry a child. We went with universal verbal screening, which I'll talk a little bit about from a legislative session in a minute. We were already screening for alcohol and tobacco. The American College of OBGYN recommends screening for all of these, so this is really nothing different. And our actual Hollister forms that many people use across the United States for obstetrical prenatal intervention and visits already specifically separate out tobacco and alcohol. We went with universal verbal screening and then targeted lab screening based on the results of that. And I'll talk about what screen we used based on that, and then worked for improved funding for social services and child welfare and have really brought our DCS team along with us, or Child Protective Services, it's called in many states. What we found and what we know is, next slide, when we started this task force back in 2014, we were having a significant increase in NAS and a significant increase in length of stay for our babies. So it was our legislators who actually asked us to better define NAS and to actually collect statistics with regards to this. We launched this program with just 4 pilot hospitals that volunteered in the state, and then expanded that. These numbers are way behind. We're actually at 36 of our 86 delivering hospitals now across the state. And most of the data that you will see is provided through 21 of those pilot hospitals. I'm sorry, 30 of those pilot hospitals. And the goal was really just to try to better understand the number of babies that were born drug exposed in the state of Indiana. One thing that we definitely had to do, next slide, was to confirm the definition of NAS that all of our delivering centers were using. NAS, people were sometimes saying, hey, it's only if you had to use medication. Other people were diagnosing NAS for individual babies that were exposed, but they had modifying Finnegan scores. And what we found is that there was no consistent way that those Finnegan scores were being done. So this is the way that we have defined this for our pilot programs. And basically, it's a symptomatic baby, and either the baby has a positive toxicology test, or the mom has a positive toxicology test, or a positive history of a positive verbal or toxicology test. Next slide. The biggest thing that we had to get over to get patients in the door was destigmatization of substance use disorder and pregnancy, not just for our patients, but also for our providers. And there was a significant issue out there with having enough providers that were willing and able to do this. When the American College of OBGYN has looked at this, 62% of OBGYNs felt that they had inadequate training in this area to deal with substance use disorder and pregnancy, and 91% had not been trained with prescribing buprenorphine, which is the medication-assisted therapy of choice. And there was a lot of hesitancy amongst OBGYNs, not only nationally, but in our state, saying, you know, we don't have the resources to care for these patients. And my point to them was, you are caring for these patients. They're walking in your door every day. They're delivering their babies. The bottom line is we just need to get on the front end of caring for them. The validated verbal screen that we decided to use was 5 Ps rather than 4 Ps because it added in peers. So partners, parents, peers, past and present. We do have a few of our currently 36 delivering hospitals that did universal urine screening as their initial visit, along with the validated verbal screen that they did. We looked into doing that from a legislative standpoint, and in discussions with the American College of OBGYN and with the American College of OBGYN's legal and legislative branch, and also SAMHSA, elected not to go with any type of mandatory verbal mandatory urine or blood screening. And what we've done, the programs that are doing that are very clearly with the verbal screening telling women that they would like to be able to urine drug screen them at the same time. Women obviously have the chance to opt out of that. We then had to work with an obstetrical team to help them provide medication-assisted therapy, and that has required involvement of addictionologists. Some of our obstetricians have gotten their MAT waiver to be able to do that, and that's what I think works the best. We've had some family doctors involved in this, but the important thing is that they were intimately involved in the actual programming and care, so that they were in the same clinic, along with the mental health professionals, along with the patient care coordinator that we're now calling an OB navigator, that basically could address those social determinants of health that became such a barrier to individuals getting into care and staying in care. We also did required inpatient care for some patients to be able to, number one, with open DCS cases, come to an inpatient care for a 6 to 8 week period of time and then transition into outpatient support and care. And then for OB patients to actually bring their children. And that was really mostly to get them out of their environments, away from other family members, peers, et cetera, that were using, and to be able to bring their children with them. So the care that we have actually allows them through Volunteers of America and Indiana State Department of Health in our Fresh Start programs to bring up to 2 of their children under the age of 5 with them. We have that care in Marion County, Indianapolis, which is our largest city. We have it in Winchester, which is in northern Indiana, and 2 more coming on in southern and in central Indiana on the east side of our state where issues are higher. We also then standardize the NAS treatment and diagnosis, as I mentioned, and I want to mention here that we have a program that's using sublingual buprenorphine with very, very good results with shortened length of stays for babies and also improved outcomes with that. And then the big part of this, and this is all put into a toolkit that's available online, and I'll be happy to give you that resource if you would like it. But basically, a big part of this was the discharge planning for both moms and babies. We were able to extend postpartum care for substance use disorder and pregnancy and get Medicaid to pay for that. And that's been extremely helpful. But then that transition off of the obstetrician's panel and onto a family doctor or another healthcare provider's panel so that those patients are still being cared for, but it opens the panel up for our obstetricians to see more patients with a substance use disorder. We did a lot of work with how babies should be able to be transitioned and how first steps should follow up and what kind of follow-up, and that education and communication to the primary care pediatricians and family doctors that would be taking care of those babies. Next slide. This is the 10-panel cord that we've used to screen umbilical cords of babies that were considered to be at risk. And we defined an at-risk baby as a baby that came in and was symptomatic, a mom that came in without any prenatal care whatsoever and delivered, and we would save every cord, a piece of cord from every single baby. Any baby that became symptomatic, and we tried to extend that 48-hour stay to get women to go home as close to 48 hours as possible. We had the cord and could then send that for follow-up. And also women that had positive verbal screens, positive tox screens on their urine or blood or a history of use. We have tweaked this 10-panel cord based on the drugs that we have seen in the state of Indiana. Our original alcohol testing was not very accurate, so we've replaced that. This screen costs on the umbilical cord about $134. The turnaround time is 24 hours for the initial screen and 48 hours for confirmation to get that back. Medicaid, private insurance, our nursing from our hospital are basically eating that cost. Next slide. So when we looked at our results in over 70,000 births that were involved in those 31 perinatal hospitals, what we found is that we tested over 13,000 cords of babies that were considered to be at risk, and that was about 18% of the births. In those births, we found that 37% of the cords that were tested were positive, and that represented about 6.7% of all the births. The NAS diagnosis was 6.6% of all the cords tested, but we found that was 1.2% of all births. And so our rate of NAS is 12.1 per 1,000 live births in the state of Indiana. When we did look at it, the average length of stay for our buprenorphine babies across all of our centers was much less than our methadone babies, and methadone actually had worse outcomes than many women who were not on medication-assisted therapy. We also have some information about needing further drugs to manage the NAS. Next slide. And this is the positivity slide. Oh, I'm sorry, you really can't see the light blue on that very well. I hope you can see it on your computer screen better than I can see it. But basically, this is from the USDTL lab in Chicago that ran all these labs. So USDTL was considered to be more the national comparison. And then Indiana's in the light blue. We had 12% of these cords that tested positive for opiates in our at-risk population, and 17% of our cords that tested positive for cannabinoids or marijuana. Interestingly enough, which we knew, and this is what led to our legislation, is that buprenorphine tested about a third of the national level at 3 versus 10.2. So that indicated to us, obviously, that we were not doing a very good job of screening women for substance use disorder and pregnancy, identifying them and getting them into treatment. Next slide. So what we did is and that's the second part of 1007, which is now House Enrollment Act 1007, was that we added universal verbal screening for substance use disorder with requirement for referral or treatment. And knowing that we will identify areas of our state that are actually not well staffed with addictionologists and or medication-assisted treatment providers or mental health providers. We've already been doing this, as I mentioned, now in 36 of our 86 delivering hospitals. So we're developing a lot of these resources around the state. But by making this a mandatory verbal screen, which is nothing different than what the American College and the American Academy of Pediatrics already recommend, we are really going to identify, I believe, more women. The concept of OB navigators is really important here because the program has found very quickly that we could have obstetricians involved with this. We could have mental health providers that came in and saw patients at every visit with the obstetrician or after the obstetrician. But if we did not have someone who could help manage patients' ability to have transportation to their clinic, to be able to put food on the table, to be able to keep their lights on, to be able to have a roof over their head, that we were not going to be able to make an impact on this. So the OB navigators are actually, as of July 1st, in the state of Indiana, reimbursed by Medicaid. And we did that through a plan amendment. And so they really can charge under a provider's Medicaid number. And that in some places is through our local health departments, and in other places is through a hospital or clinic provider. Next slide. That's, I think, all I wanted to give you information on today, and happy to answer any questions.
Thank you so much, Dr. Box. I really appreciate that presentation. For folks, thank you so much for your questions. Please keep them coming in the chat box, and we'll get to them after our last presentation. I'm happy to introduce our third presenter today. Indra Lucero is the staff attorney for the National Advocates for Pregnant Women. Indra is a reproductive justice attorney, entrepreneur, and patient advocate. Indra, over to you.
All right, thank you. Thank you for having me here. I'm delighted to get to talk to you all about this important subject, especially at the beginning of your journey through the PRISM Policy Academy and as you develop projects in your state. I just want to say a little bit about National Advocates for Pregnant Women and what we do. We're a nonprofit organization that works to secure the human and civil rights, health, and welfare of all people, focusing particularly on pregnant and parenting women and those who are most likely to be targeted for state control and punishment: low-income women, women of color, and drug-using women. We believe that human and civil rights are an essential ingredient in health and welfare. The first thing I want to note is that not all drug use is a substance use disorder. Everyone knows people who use various amounts of alcohol, nicotine, prescription medication, and other substances. And these are not all people with substance use disorders or who are bad parents needing to be reported to child welfare. So with the goal of emphasizing human rights, I want to start by asking you to call into mind this full range of people and to humanize them, give them nuance and complexity. Next slide. I really hope to complement your consideration of clinical issues and the information that the doctors have provided with information about the social and legal context of these clinical decisions, which includes thinking about how the law can be a useful tool, what the context of perinatal health care is in general, and how information about the social and legal risks of drug screening, testing, and mandatory reporting go along with an eye toward how you can each innovate and identify opportunities in your states. Next slide. So with this image, I just want to ground everyone in what the law is. It's a combination of cornerstone documents like the Constitution, written statutes, and common law, which is the law that evolves out of tension between competing interests that are resolved through trials. This system provides a way for dealing with all kinds of tricky issues and hard decisions and complexity. That's what it's for. It provides a way to get perspective, to remember principles like liberty, or to clarify power like federal versus state or constitution versus statute, and the importance of due process, that there be a fair set of steps taken when somebody's liberty is challenged. The law can be a good check on our impulses. The process pictured here is how we evaluate whether our impulses and ideas can survive a deeper analysis. And it's important to remember that there is, in fact, a hierarchy to these rules, that the Constitution is the higher power over regulations or policies, and that in the Constitution we have principles that protect patients, that protect patient decision-making and patient liberty, and that those rules apply to pregnant people. There's a U.S. Supreme Court case, Cruzan, decided in the 1990s, that establishes the constitutional right to refuse even life-saving medical treatment. And this case really underscores the informed consent process that is a requirement in all medical decision-making. And again, that's a process and not just a form. Further, we have a couple U.S. Supreme Court cases from the late 70s recognizing the dominant role of the parent in medical decision-making. Next slide. So when we start to think about substance use in pregnancy, we have to think about the kind of care that pregnant people receive and the kind of system that they're interfacing with in the context of their pregnancy, aside from or in addition to the treatment they may need with regard to substance use. And unfortunately, this is not a system that is working very well. As Dr. Box alluded to, even in her state, where they're experiencing particularly high rates of maternal mortality, the same is true in the U.S. as a whole. We have, in fact, rising maternal mortality and morbidity. We have inequitable disparities. We spend more than any other developed nation, but have worse outcomes. And we have a disproportionate focus on the fetus at the expense of the mother. Unfortunately, in the context of perinatal health care in general, racism and implicit bias is an issue. The CDC just released their findings that Black women and Native American women had pregnancy-related mortality ratios 2 and 3 times higher than that for non-Hispanic white women. More and more research supports the theory that racism is a factor in this disparity. But again, this is a system that's not working as well as it should for anyone. So we should consider the impact of introducing new policies or procedures into this landscape. So for example, we know that current drug testing policies and practices disproportionately burden women of color. This doesn't just mean that women of color are more likely to be tested despite comparable rates of use, but that once screened or tested, a child is 72% more likely to be taken away if the mother is Black. And when caseworkers are given hypothetical situations and asked to evaluate the risk to a child, the scenarios being identical except for the race of the family, consistently, if the family is Black, the workers say the child is at greater risk. Parents regularly describe losing their child through the child welfare system as a severe deprivation, more severe than being sent to prison. And it's worth noting that in both Indiana and Ohio, they're among the 5 states with the highest number of infants in foster care. So we know that a lot of women in these states are experiencing this severe deprivation. Next slide. Unfortunately, the existing perinatal health care system includes more and more punitive policies and even the criminalization of pregnant women. At this point, we've documented over 1,200 instances since 1973 where a pregnant woman is charged with a crime or forced to treatment or into a medical procedure that, but for the pregnancy, there would be no crime and no grounds for force. 84% of the cases we identified were arrests involving being pregnant and using a criminalized drug. Others had to do with an outcome of pregnancy, including abortion, miscarriage, or stillbirth. And this number of cases of criminalization, again, doesn't even address the number of deprivations related to child welfare involvement, which is a much higher number. I wanted to note some highlights from our research relevant to the states that some of you are working in. For example, it may be of interest to the folks in South Carolina that the highest proportion of cases in our study actually came from South Carolina. It may be notable that some of our most well-known cases happened in Indiana, including that of Bebe Shui, who's pictured in the bottom left corner. And she was charged criminally for her attempt at suicide during her pregnancy. Iowa is also a state where we've had a particularly notable case where a woman was criminally charged when she fell down the stairs because of potential risk to the fetus. And Arkansas is a place where we've worked with Miss Bynum, who was charged with concealing a birth and abuse of a corpse after she experienced a stillbirth at home and brought the fetal remains to a hospital several hours later. It's also worth noting when we think about, these are the folks that we work with, and these are the folks who we see being impacted by punitive policies, specifically punitive policies related to substance use during pregnancy. But in fact, a recent study out of Advancing New Standards for Reproductive Health found that policies targeting alcohol use during pregnancies are increasingly punitive, and that harms related to substance abuse during pregnancy can actually come from both the substance use itself and from policy responses. In fact, these punitive policy responses are harming rather than helping. Next slide. So when we talk about screening and testing, we have to remember that we're talking about doing that in the context of a system that's not working very well, where there are racial disparities and biases and poor outcomes, and where patient needs are not being met. Screening and testing often contributes to when informed consent doesn't happen and the patient-provider relationship being undermined. For example, the false positives that result through the immunoassay tests can have serious social and legal consequences for families. So it's not just a matter of clinical risk we have to think about. Even though it's true that pregnant and postpartum women have the right to refuse any medical procedure, including a drug test, and they have the right to refuse any medical procedure on behalf of their children, with some exceptions related to child abuse and neglect, we don't see that always being honored. Another thing to consider is the use of drug screening and testing, and what the process is for reconciling the patient-provider relationship when a test is used to discover or to expose that a patient has perhaps been lying. What are the standards and policies we use to deal with that, and how can we improve care in that gap? Next slide. Mandatory reporting is also happening in the context of this broken system. In fact, mandatory reporting has not been proven to reduce child abuse or increase prevention. The idea that prenatal substance exposure amounted to child abuse is really an idea that's been debunked. It's a relic from the crack baby myth. And in fact, what happened with pregnant women using cocaine in the 80s and 90s is a good example of why and how the law is important. The myth of the crack baby led to many child removals, traumatizing many women and their children, removals that took place based on bad science. And the law should have and could have done a better job at protecting those families. And today we can do a better job. We understand now that staying with those moms would have been better for those kids. And we have the legal principles in place that would allow us to err on the side of protecting families, keeping them intact, protecting their health care privacy, and protecting parental rights. I did want to note here with the asterisks that even though the rule for mandatory reporting is that you only have to report if you have a reasonable suspicion of abuse, there are some states that include a positive test at birth in the definition of abuse, like Colorado, where I work. And that can put providers into a legal gray zone and can be confusing and uncomfortable. But I would just encourage folks to think about mandatory reporting as a bridge. And if you don't think it's a bridge that has integrity, then you're not going to use that bridge. You know, even if the law says you have to, you're gonna minimize your use. You're gonna be strategic and prioritize when you use that bridge. If your goal is to prevent abuse or protect or to treat or support kids dealing with neglect or abuse, you should, as a provider, ask yourself, is this the right bridge? Is this going to get me there? And we don't have data to suggest that mandatory reporting does that. Next slide. So I just want to highlight two things here. First, that there are social and legal risks to screening, testing, and reporting. Second, that making screening and testing universal doesn't eliminate the risk of bias or the disparate impact on families experiencing screening and testing. Just because you test everyone equally does not mean that everyone will get referred to treatment equally, reported to child protection equally, investigated by child protection equally, have a case opened equally, have an infant removed equally, be given visitation equally, or judged equally as to whether they're a fit parent. And at the bottom of the screen here, I highlight a useful study along these lines. When it comes to substance use in pregnancy, we're often thinking about risks to the fetus, but we also need to broaden our view and think about other risks, legal risks, the risks of policies themselves, and the risks to our human rights. Next slide. So just to recap, in grappling with these complexities and tensions, remember that the law can provide some useful tools. Patients do have a right to refuse, and that's a very high priority right. Due process is also a very high priority right. Mandatory reporter laws are in conflict with patient confidentiality, and especially when mandatory reporting fails to prevent or address child abuse, you should consider erring on the side of maintaining confidentiality. Also, of course, watch for implicit bias. And think beyond the clinical. How can you protect human rights and civil liberties in order to protect the health and welfare of the people in your state? Next slide. In fact, you do have opportunities to help change the system. You can use your power with discretion. You can consider ways to improve things for pregnant people who use substances by improving things for pregnant people in general. For example, improving postpartum care is a big area of need and a place where we can help substance-using pregnant folks. Improving the patient-provider relationship and interactions. The Mothers on Respect is a tool. Let's see, it looks like I didn't realize I had animated these, so go ahead and just click through all of these. The MOR tool is Mothers on Respect, which is a reliable patient-driven quality and safety indicator co-developed by mothers, and that can be applied in different settings to measure the nature of patient-provider relationships. Perhaps in places that are considering universal screening, first evaluating the current conditions with regard to patient-provider relationships could be a good place to start. Also consider ways you can improve things for pregnant people with substance use disorders by improving things for anyone with a substance use disorder. Thinking about how privacy and confidentiality is part of good care. And oppose punitive policies by just not participating in them. Know that by making a report, especially making a report to law enforcement, it could have very dire consequences for the people you're trying to serve. And finally, you can seek solutions that don't just satisfy the law, but you can improve or exceed the law. I'm happy to share an example from New Mexico, where just this last legislative session, they passed House Bill 230. And the language of 230, I think, is useful and could be a guide for everyone. It says, a finding that a pregnant woman is using or abusing drugs made pursuant to an interview, self-report, clinical observation, or routine toxicology screen shall not alone form a sufficient basis to report child abuse or neglect to the department. So I just want to leave you with that great example from New Mexico. And last slide. Just let you know that we are available to support you, answer any questions, We've provided some of our fact sheets related to these issues, and you're welcome to reach out at any time with questions or concerns. Thank you.
Thank you so much, Indra. So I see we've had several questions come in over the course of the speakers.